Good morning. We'll go ahead and get started here. It's my pleasure to introduce Aude Chapuis from the Division of Medical Oncology. She completed her medical school training, internal medicine residency, as well as a medical doctorate in Switzerland with her initial work in HIV immunology. She then came to Seattle and did a postdoctoral research fellowship at the Fred Hutch with some continued work in immunology, and then did a medical oncology fellowship at the University of Washington. She then joined the faculty here and is an assistant professor, as well as an assistant member of the Fred Hutch. She has received numerous awards, including American Society of Clinical Oncology Cancer Foundation Young Investigator Translational Cancer Research Award, and most recently the V Foundation Cancer Research Award. Adding to the work she's done in HIV immunology, her current research focus is on modulation of the immune system to target cancer. This includes use of autologous T cells targeted against cancer proteins. She's investigating their use in treatment of metastatic Merkel cell carcinoma, leukemia, as well as non-small cell lung cancer. We're pleased to have her here today to talk to us about cellular therapy, including transgenic T cell receptors for solid tumors. Please help me welcome Dr. Chapuis.
Thank you very much. Thank you very much for inviting me today to present my work. I want to start very basic and talk about T cells and what is the mechanism of T cells and what we're trying to use to target cancer. So essentially here you have a CD8 T cell. So a CD8 T cell, can you see my arrow? Yes, you can. A CD8 T cell has a very specific T cell receptor that it has rearranged, and it's unique to this cell. And it can recognize a small peptide presented by an HLA, which is also restricted. And the HLA, all cells, including tumor cells, have a mechanism to go fish whatever is inside their cytoplasm and bring it up to the surface so that the T cell receptor can actually recognize very specifically this particular peptide in the context of MHC. The CD8 T cell, the CD8 co-receptor then binds to this construct. This is called signal 1. This gives the cell a positive signal. The T cell starts to secrete perforin and granzymes, which makes pore through the T cell, through the target cell. The target cell dies, and in theory, the cytotoxic T cell can then move on, detach itself from that, move on, and go kill other cells. So to dissipate confusion, especially with recent coverage in the news, I do want to differentiate what we are doing, which is the T cell receptor from the CAR T cells that I'm sure you've been hearing a lot about. So CAR T cells are a human-made construct. They're usually an antibody that comes usually from a mouse, which can recognize a surface protein on the surface of a cancer cell. It's obligate to recognize a surface protein because it's an antibody, and it's linked to the intracellular portion of the T cell receptor plus some other co-receptors, and it makes the T cell function. Now, a T cell receptor can recognize intracellular proteins that are presented in the context of MHC, so it is not restricted to surface proteins. There are some particularities, of course, is that it's restricted to HLA, so not everybody has the same, not everyone has the same HLA type. The other particularity is that these T cell receptor constructs, so they're natural. We make them every day in our bodies, and they are not usually immunogenic, whereas the CAR T cells are. And they have a very different toxicity profile. Okay, So the types of tumor-associated antigens that TCR therapy can target, first of all, there's tumor-specific mutations, which are very specific to a patient and his tumor. There are some viral antigens. There are a number of tumors that are driven by viruses, including HPV, Merkel cell polyomavirus, which we will talk about later, EBV, for example. The viral antigens are non-self. They come from a virus. So usually the affinity or the strength of the T-cell receptor that recognize these polypeptides or small peptides is usually stronger. There are overexpressed self-antigens, meaning these are antigens that we all have, but in certain tumors they're overexpressed, and T cells can differentiate between the normal expression in normal tissues compared to overexpression in tumor cells. Here, for example, MARP1, which we'll be talking about, which is the color in melanin, and usually expressed in melanoma. Tyrosinase, WT1, mesothelin, all those are overexpressed self-antigens. And then there's this very particular category of cancer testis antigens, which are expressed during fetal development, but then their expression is completely shut down. And certain tumors will reactivate the expression of these tumor antigens. These tumor antigens are very interesting in the sense that they are really, their expression in normal tissues is nearly, you really cannot find them. So they're nearly like viral antigens, but in the self-antigen category. So how can we exploit the anti-tumor potential of T cells? And we started doing this work more than 10 years ago now, where essentially we would take PBMC or cells from the patient, isolate and enrich them using peptide pulse dendritic cells to a particular peptide. And then we would clone them by limiting dilution, where we put one cell per well. We would select the best clone and expand those using non-specific expansion protocols to expand the cells to billion and then reinfuse them into the patient. A number of trials were carried out in melanoma. Melanoma was really the type of tumor which seemed to respond best to immunotherapy, and probably that's why a lot of these trials were carried out in that setting. Except that when we were infusing these cells, even if we were infusing billions of cells, you have to realize that they came from one cell only. And we saw a very shortened persistence. Essentially, depending on some trials, there was only 1 or 2 patients with persistence. And of those patients who had persistence of the cells that we had infused, only very few had responses. So so one of the things that is important to consider is that the T cells have a differentiation process essentially from the time that they recognize their antigen on the antigen-presenting cell. They go through a differentiation process. The current model goes from a naive cell to a central memory cell, which then becomes an effector memory. The proliferation capacity of these cells decreases over time, and they also have slightly different characteristics and can be recognized as such. And so when we actually looked at the cells that were persisting in the few patients who had received T-cell clones, what we saw was that the cells that were there and that were most likely to have eliminated the tumor in certain patients had characteristics of central memory cell. Essentially, they had markers that made them more like a long-lived memory cell, essentially that could survive for a long period of time in the body. They expressed, I'm just going to go over them because we're going to talk about them later, but CD27, 28, 127, CD62, and CCR7 are markers of, canonical markers of central memory, and they were functional and secreted the IL-2 and interferon gamma. And these observations were suggestive of studies in primate cells and also murine modules. models where they had taken either central memory or effector memory, expanded them in vivo, sorted them, expanded them in vivo. They could not differentiate them right before they put them in the mouse or in the monkeys, but when the cells were back into the mouse or the monkey, they would basically revert back to what they originally stemmed from. So, of course, we were not satisfied with the results that we were getting, and how could we try to ameliorate, increase the patient responses rates in for T-cell therapy? First of all, we focused on ameliorating the T-cell generation process. We used polyclonal population of antigen-specific cells, so basically we would start out with a higher diversity of cells. And we looked also in strategies to generate T cells from pools that contain central memory cells to try to prolong the persistence in vivo. But as I showed before, there was also the naive cells may represent also an even better substrate population with an increased proliferative capacity upon antigen encounter. And those cells could also be interesting for as substrate for adoptive transfer. We also tried to make the T cells more effective, combined with checkpoint inhibitor blockade, or genetically modify the T cells to express a T cell receptor with a higher affinity, so a stronger that would recognize the target better. So the first thing we did, now we had better machinery, essentially a multi sorting capacity now in GMP and in the clean room, and so we ameliorated the process by isolating and enrich again cells, but this time using sorted population and then expanding them back into the patient. This total production time was now decreased to 4 to 6 weeks compared to 10 to 12 weeks before. We also used IL-21 during the in vitro stimulations. IL-21 is a cytokine which promotes the expansion of responding T cells that are less terminally differentiated, so less effector, more memory, or which have a more proliferation capacity. And we had also previously shown that increase in vivo persistence was observed in murine modules, but also human models when naive cells were primed with IL-21. Therefore, the goal was to develop culture conditions that program the generation of T cells with less terminally differentiated phenotype. The first trial that we did was for stage 4 metastatic melanoma patients, where we infused now these enhanced T cells, about 10 billion cells per meter squared, which is a relatively standard dose in the world of T cell therapy, preceded by low-dose cyclophosphamide to try to make room for the infused cells, and followed by low-dose subcutaneous IL-2 in combination with anti-CTLA-4. Anti-CTLA-4, just a quick reminder, blocks CTLA-4, which can bind to B7 on an APC, and so basically an antibody that blocks CTLA-4 will inhibit the natural inhibition that a T cell has the moment that it actually recognizes its antigen. So by blocking the inhibitory signal, we think that we could increase the activation of T cells. Now, if you give ipilimumab alone, it does prolong the progression-free survival. This is progression-free survival here. However, the number of patients who respond to anti-CTLA-4 alone is very low, in the range of about 0 to 7% on the long term, depending on the clinical study. So when we actually infuse T cells, giving the anti-CTLA-4, if you will, a substrate that could act upon, we treated a total of 10 patients. The overall survival was about 50%. Here this is about 2 years. And we did see that 2 of these patients really had completely eliminated their tumor, had persistence of the cells, and were free survival now up to 5 years. So we tried to figure out, what exactly, what was the qualification of successful adoptive transfer. Of these two patients, I'm going to take the example of one who had received monoclonal T-cell clones previously and had not responded. Here, these are his lesions. He had very important lesions in the subcarinal area and also in the right hilar area. And he had not responded to anti-CTLA-4 alone. He progressed, but when he did receive the polyclonal T cells plus a short course or standard course of anti-CTLA-4 for 12 weeks, he started to have a very slow regression of his tumor. He was tumor-free at 1 year. He developed vitiligo, which is a sign that the MART1 specific T cells that we had infused were working, since MART1 is the color in melanin. And essentially remains free of disease a long time afterwards. If we looked at the T cell persistence, this is the T cell persistence that we were able to obtain with T cell clones. And when we infused the enhanced T cell plus anti-CTLA-4, we saw that he had a robust now CD8 T cells that were persisting in his blood, and at 5 years he actually had 4%. Even though what we had infused, the polyclonal product, was very diverse, and this we can find out by sequencing the T cell receptors and the diversity of T cell receptors that we're infusing, the majority of the population that was surviving was just one clone. And this clone was certainly had a memory phenotype with CD28, CD612, CD7, had low expression of PD-1, which is an activation exhaustion marker, and were very functional cells in secrete interferon gamma, TNF-alpha, IL-2 upon cognate antigen encounter. One other thing that we saw in this trial, and not only in this patient, was epitope spreading. Essentially, now that he had a robust response against his own cancer, he was able to make new responses. So against epitopes that we were not targeting. We were targeting MART1, but now he developed CD8 and CD4 T cell response to NY, so GP100, tyrosinase, MAGE-A3. Those are just the proteins that are commonly expressed in melanoma, and that he developed responses to. This is a phenomenon called epitope spreading. So essentially, what we showed in this trial was that the toxicity profile of antigen-specific T cells plus ipilimumab was comparable to ipilimumab alone. And the immune monitoring revealed the combination was potentially mutually beneficial by enhancing the persistence of functional T cells and also epitope spreading. So could this effect be broadened to other tumor types? And it turned out that at the same time, in collaboration with Paul Niem, we were looking at Merkel cell carcinoma. So Merkel cell, just a few background on this, is a highly aggressive therapy-resistant neuroendocrine tumor, which with mortality rates a lot higher than melanoma. It is driven by the Merkel cell polyoma virus in 80% of all MCCs. And the Merkel cell polyoma virus needs to be mutated and integrated, and it is actually the driver of the tumor. So Paul's lab had identified T cells that recognize epitopes of a common sequence on the Merkel cell polyoma virus that were restricted to different HLA, A24, A2, and HLA-B3502. And remember, this is really a viral antigen. So we thought to use these T cells in a clinical trial. Now, a particularity of Merkel cell carcinoma is that it downregulates MHC class 1, and if you remember, you need to have the MHC expression on the surface of the cell so that the T cell can actually recognize the peptide in the context of the MHC. And however, this downregulation of MHC class 1 is reversible, either by injecting interferons directly in the tumor, by poking the tumor and administering it directly, or by low-dose radiotherapy. Anywhere from 4 to 8 gray is sufficient to reactivate, to re-express MHC class 1. Now, we designed a pilot trial to administer T-cell infusions to these patients with metastatic Merkel cell. We did, a few days before we would infuse the T-cell, we did an MHC class 1 upregulation intervention and infused our classic amount of 10 billion cells. And the patients could actually have 2 rounds of therapy. We treated 4 patients on this particular combination, and they got anywhere from 2 to 4 infusions, a high range of HLA types. All of them had and were resistant to previous therapy. But the results that we were obtaining with just T cells alone was insufficient in the sense that we treated, of the 4 patients we treated, 3 of them eventually progressed. Only 1 had a complete regression. When we looked at the persistence, that were the cells that we were giving actually persisting in these patients, we saw that yes, in 3 of the 4 cases they were. But when we looked in more details at the expression of PD-1, which is this activation exhaustion marker that we can actually target by current checkpoint inhibitor therapy, we saw that only the 1 patient who had a response in a complete remission had persistent cells which were not PD-1 positive when we infused them in and remained not PD-1 positive, so they lacked PD-1 when they were in the patient. So a quick reminder just to what is PD-1. So PD-1 is the ligand of PD-1 is expressed on tumor cells or antigen-presenting cells, and it binds to PD-1 on the T cells, which then sends an inhibitory signal to the T cell. We now have antibodies that block this interaction, either anti-PD-1 antibodies or antibodies that bind to PD-L1, and both have a similar effect. So we designed a trial to now combine the T cells plus the anti-PD-1 in this particular case. And this trial has been open since a few months, really, and we have not treated many patients on there, so I will show only results for the group 2, which is the combination of T cells plus the anti-PD-1. Now, of the 3 patients that were treated, we had 2 complete regressions at 8 weeks. So remember, these are patients with metastatic Merkel cell. They cannot have any more surgery. It's hopeless at this point. 1 patient had actually progressive disease before he responded. And we'll look a little bit more closely at this patient. This patient was treated off protocol because it was before we had access to the anti-PD-1 blockade for this particular combination. So he received anti-PD-1 before the T cells, then he received 2 infusions of T cells. He had nice persistence. But then he progressed, and Shailander Bhatia and Paul Niem, who were treating the patient at this time, had the brilliant idea to combine the anti-PD-1 infusions that he was getting with low-dose anti-CTLA-4, so giving really a very small shot. And this patient had actually a very large and growing lesion in the retroorbital area, which was causing blindness and diplopia, which after the start of the combination therapy completely regressed. And at this point, he doesn't have any symptoms anymore. So basically, the tumor went away completely, melted over the course of a year. He also had very important masses surrounding in the retroperitoneal area that was cutting the blood flow to the kidney, and all of that resolved over the course of a year. When we looked at the cells, the persisting cells in this patient, so these patients do have very small amounts of T cells that recognize their Merkel cell polyomavirus, and when we looked at in this particular patient, we saw that about 50% were PD-1 positive. After T cells plus the checkpoint inhibitor blockade, we were able to increase the frequency of cells recognizing the tumor to about 15%, and only a very small fraction now express PD-1. The tetramer positive cells, so that's how we can recognize them in vivo, express memory markers, very little activation and exhaustion, not only PD-1, but also other activation exhaustion markers suggesting they remain functional, and we're also able to secrete cytokines upon cognate antigen recognition. The other thing which I didn't mention was that this combination was extremely safe. The patients get fevers and chills maybe within 24 hours of getting the T cells, but otherwise this is associated with no other side effects. And this is all given in the ambulatory setting, so no hospitalization whatsoever. The transfer cells still persist in a functional state, but one of the major issues with this approach is that we are really relying on what the patient already has. And T cells could not be efficiently generated for all patients, or they could be generated, but not to sufficient numbers. So this really brings us to the rationale for introducing an antigen-specific T cell receptor in a target substrate cell population. So the immune responses capable of eradicating established tumors are obviously inadequate in most malignancies naturally. There are low absent frequencies of tumor-specific cells, as was the case in Merkel cell, but it's also the case in many other tumors. There's insufficient function, and the cells that you can find are exhausted. They've already seen their targets and proliferated, and so they're kind of at the end of the line. And immune tolerance towards tumor-associated self-antigen is a very high barrier towards high affinity of cells. So the theory now is that you can introduce in a cytotoxic T cells of your choosing. You can decide which one you want, a naive cell, central memory, or a virus-specific cell, and introduce an engineered T cell receptor. So we started with Phil Greenberg at the Hutch. We looked at targeting WT1. Wilms tumor antigen 1 is a protein which is overexpressed in AML, ALL, CML, and at higher levels correlate with a worse prognosis. It's a self-antigen, so there's low-level expression in adult kidney podocytes, testes, Tolli cells, mesothelial lung cells, but usually CD8 T cells, especially those elicited by a vaccine, can actually make the difference between WT1 expressed in the tumor and in normal tissues. We did a trial. So just the few words on high-risk AML. So, and which will lead me to the setting where we did these T cell infusions. So high-risk AML. These are defined by patients with unfavorable cytogenetics. So they have a tendency, their disease has a tendency to come back despite multiple rounds of chemotherapy. They're refractory. It's usually therapy related to AML, AML arising from previous hematological disorders. Even if these patients undergo a transplant, they have a high tendency to relapse. Options after they relapse after a transplant are dismal. We can withdraw immunosuppression, reintroduce chemotherapy. We can do another transplant, but whatever intervention we do at that time is usually poorly tolerated, and the probability of these patients dying is pretty much 95% after. So we had done a trial where we had treated 11 patients with high-risk AML In the post-transplant setting, so the cells were generated from the donor and given to the patient after their transplant, which was targeting an HLA-A2 restricted epitope of WT1. And we saw that this was safe. There was no injury to normal tissues. And we also saw some direct, albeit transient, evidence of anti-leukemic activity. This was in one particular patient, where in red here are the blasts, which decreased the moment that we had infused the cells. The cells were clonal cells at that time and were not persisting a long time. But the times that they were in the peripheral blood, they were able to eliminate the blasts. So to make a long story short, we screened all the patients that we had treated and also normal donors to try to find a T-cell receptor targeting WT1 with a high affinity. TCR affinity is a major determinant of T-cell avidity, or how efficiently a T-cell can kill its target. So we thought that expressing a higher affinity T-cell receptor may be associated with a better recognition of the WT1 expressing tumor cells. This is a process that took 4 years because we went through the grinding screening of every single clone that we could find from every single donor. We were able to identify the C4 TCR, which came from a normal donor and introduces into a retroviral vector. And when we use this retroviral vector now to express this new TCR in normal donor cells, we saw that the avidity that this T-cell receptor conferred to the cells that were transduced were comparable to the highest avidity by 2 measures, both peptide titration and killing of a naturally expressing WT1 cell line compared to what we had, what the patients had received in our previous trial. This TCR was also able to induce the killing of fresh leukemia cells. Now, we're in the post-transplant setting, so one of the major issues there is we try not to induce graft versus host disease. So in order to avoid that, we thought that we could take the donor cells, essentially from their G-mobilized leukapheresis, what they give to the patient, and take a portion of that and stimulate with the EBV or CMV. So we thought, since now these cells are going to contain 2 T-cell receptors, we thought that if the endogenous T-cell receptor was virus-specific cells, our probability of inducing graft-versus-host disease in the patient after cell transfer was minimal, and that's why we chose EBV and CMV, which are very common viruses. That a lot more, about 90% of the population will have one or the other. And transduced with our C4 TCR, we use now cell sorting techniques with multimers or tetramers to select the double positive T cells, expand these, and then infuse them into the patient. At this point, we've treated about 20 patients. The 5 first patient completed, this was a safety trial, of course. This is the first time this was used in humans, and we very rapidly found out that this was safe, that was not inducing graft-versus-host disease, and we asked the FDA to shorten the dose escalation to go directly to the highest dose, which we did, and we treated 16 patients that way. The patients were treated in 2 different arms, the prophylactic arms, essentially patients and coming into transplant with high-risk AML, but who did not have any detectable disease right after transplant. And these patients all received EBV-specific cells, and a second arm where the patients had relapsed after the transplant, or if you will, a treatment arm. And in this particular group, 4 patients had received CMV-specific cells, and we'll see why this is important afterwards. So just a few words on the toxicity profile of this approach. Essentially the same as any T-cell infusion, fevers and chills within 24 hours of the infusion, which resolves spontaneously. all treated in the ambulatory setting. And also now we have lymphopenia. This is a very classical, probably from redistribution of T cells, which is transient, less than 10 days, but essentially not really any toxicity. So it's really very well tolerated. Now, when we looked at there's many, as I've shown before, there's many ways to determine if a patient is high risk or not. And when we looked at the profile of the patients who had been treated on the prophylactic arm, they did accumulate risk factors. Some had abnormal cytogenetics, some were refractory, but essentially they were accumulating, but not incredibly, they didn't accumulate all risk factors. Now, if we looked at historically how these patients do over time, you can see that at 600 days, this is just with transplant, about 80% of these patients have relapsed. Of the 10 patients that we have been treating at this time in the prophylactic arm, none of them have relapsed, and the farthest out is about 20 months. The median days between the transplant and the first CTL infusion was 97 days. So we're not seeing direct evidence of anti-tumor activity in this particular population, but the fact that they're not relapsing suggests that there certainly may be prevention of the tumor to come back. When we look at the second arm, so patients who have received this with disease on board after their transplant, you can see that these patients are much worse off than the first arm. With a huge amount of cytogenetics abnormalities, refractoriness to multiple treatments, and a lot of them are entering transplant with disease on board, which is one of the most, which increases your probability of relapsing afterwards. So if we looked historically what these patients do, so this is the overall survival of patients who relapse after transplant. You can see that about 600 days, less than 5% are still alive. Now, in the patients who did receive the cells in our trial, we have about 50% alive at 600 days. So these patients are relapsing, but it seems at a less at a lower frequency. We know that response is in tight correlation with persistence. And when we looked at the persistence of the cells in the first arm, we saw incredible, so all these patients had received EBV-specific cells, we saw incredible levels of persistence, where about 50% of the total population of the CD8 T cells in these patients were carrying the transgene. This is also to show that, this is reproducible in many patients. Some patients did not, in arm 2, the patients who received EBV-specific cells, we saw also good persistence. So these are usually patients who have disease on board. But when we looked at the CMV-specific cells, we saw that the persistence was really not good at all, where essentially after infusion, after a peak after infusion, the people who had received the CMV-specific cells, that there was no detectable transgene anymore. So we asked the question, well, why are these EBV-specific cells seem to be so much better than the CMV-specific cells? And we looked at the time where we infused the cells, if we saw phenotypic differences in these cells, and there was really none. They really had an effector phenotype when they were infused in the patients. We looked at earlier time points after in the cell generation process, right after the sort, and we also saw no difference. We really had to go all the way back to the G-mobilized leukapheresis of these patients to see differences. And indeed, when we looked at memory markers on the EBV-specific cells here in yellow compared to the CMV-specific cells, so we're looking directly at ex vivo CMV and EBV-specific cells in the normal donors. We saw that the EBV-specific cells had a much higher expression of markers associated with memory and central memory in particular. and the expression of activation exhaustion markers was reversed, where the EBV-specific cells expressed a lot lower levels compared to the CMV. Now, CMV infection is actually characterized by continued low-level replication, which presumes that the cells that in the normal donor that are CMV specific are effector cells, that they're replicating and at the end of the line. And if you remember what I had showed you before, that effector cells are not that good at persisting after transfer. Now, EBV-specific infection in normal donors establishes latency. There's very infrequent detectable reactivations. And EBV-specific cells are present in a resting state in the normal donors. They secrete IL-2. They have less perforin upon cognate antigen recognition. So they're more memory cells. It makes sense retrospectively that the EBV-specific cells were doing so much better than the CMV-specific cells. So selecting a substrate population of cells with less differentiated characteristic enhanced the persistence after transfer. Now, to be able to, so it turns out that WT1 is also expressed in non-small cell lung cancer and mesothelioma. And the autologous setting offers a lot more leeway in what we can do in terms of adoptive transfer. And we thought we would address this question in the setting. Also, it's also a setting of a solid tumor. So just a little bit of background, patients with persistent recurrent non-small cell lung cancer after first-line therapy have an average survival of 4.7 months. So it's dismal. Mesothelioma is also is also similar. The expression of WT1 is about 30 to 80% in non-small cell lung cancer, and it's 100% in mesothelioma. And if we look at what the staining looks in these cells, so here this is a WT1 antibody in a leukemia. You can see that the WT1 expression is in the nuclear, and it's not expressed at high level in all the cells. For mesothelioma here, you can see that the expression is nearly 100% of the cells, and it's nuclear. For non-small cell lung cancer, it's a little bit different. The expression of WT1 is cytoplasmic, but it's screaming high when it is present. So we thought in this particular setting, so now we're much more free to select the substrate cells that we can plug our T-cell receptor insert in. And we thought that we would try to select naive cells and compare them directly to central memory cells, and we can differentiate these based on CD45RA and CD62L. We would sort these and then transfuse them with our WT1 T-cell receptor, select them, sort them again, and infuse the products. And using T-cell sequencing, so remember that all these T-cells have their endogenous T-cell receptor, which is like a barcode. We can now differentiate the cells that come from the central memory population or the naive population. And the overlap is around 6 to 12%, which we thought in terms of, in human terms, acceptable so that we can actually differentiate these cells in vivo. And to infuse these cells now, both the naive and the central memory population, directly into patients after standard, so either mesothelioma or non-small cell lung cancer right after their first line of treatment. This is also a dose escalation when we gave a small dose first to make sure that it was safe, followed by cyclophosphamide to try to increase the persistence of the cells, and followed by a higher dose. At this point, this trial has just been opened. The PI of this trial is Sylvia Lee at the SCCA. We've treated 3 patients, and I thought I would share the results with you where certainly this is persistence here. This is tetramers CD8 positive cells. So in the first 2 patients that received the cells, we really saw not a lot of persistence, and indeed these patients progressed after 6, 12 weeks or 20 weeks here. But in the third patient that we were able to infuse, now we are seeing a lot of persistence. So in terms of, we're not there yet in terms of guaranteeing persistence in all patients, and we certainly have to improve on that, and I'll talk about that later. But when we do find a patient with persisting cells, and we're talking about 10% of total CD8 T cells, we start to see responses. This patient these patients are all at the end of the line. They have a lot of disease on board. This is mesothelioma in a patient where she had a large lesion that was eating away through her thorax, which decreased with the after the T cells. Also, other lesions in her pleural cavity, which decreased. So we'll continue to follow this patient and see if, whether these responses pan out. But from what we know from previous T cell infusions is that these tumors have a tendency to melt away very slowly without a lot of side effects, so usually over a few months or a few years. So essentially, what I'm trying to convey here is that infusion of non or genetically modified CD8 T cells targeting tumor antigens has a very tolerable safety profile. CD8 T cell plus checkpoint inhibitor blockade do not increase the toxicity of either modality. The slow melting of the tumors and responses are seen across tumor types and across tumor antigens, which is very encouraging in general. So where do we go from here? So of course we're not there yet. I feel that this is really the beginning of a story. We of course want to expand and diversify the targeted antigens, and there's a huge effort going on to target MAGE family antigens, which can target non-small cell lung cancer, triple-negative breast cancer, bladder cancer. All these are differentially expressed in the tumor compared to the normal tissues, and we can generate T-cell receptors against them. Mesothelin, there's an upcoming trial coming to target pancreatic cancer, and Merkel cell polyomavirus, where we're also isolating a T-cell receptor in collaboration with Palmium. We want to expand the HLA restriction. We showed that right now all our trials have been pretty much restricted to HLA-A2. And if we expand the T-cell receptors to HLA-A1, A2, A3, A11, A24, B7, and B8, and B44, we could cover about more to 90 to 95% of the whole population, not just Caucasians, like A2, but really the Asian and also Black African-American populations. We want to determine, of course, the best substrate population for both persistent and infiltration in the tumor. And Dan Egan is now opening a trial where we're going to do a head-to-head comparison of the TCR transduced targeting WT1 EBV-specific cells versus naive or central memory. And we also want to engage CD4 T cell response to help the infused CD8 T cells, and this is ongoing work in the lab. So on this note, I want to so you can imagine that to carry out these trials is a huge effort. I've been working with Phil Greenberg. I've actually stemmed from his lab. Palmium and his group collaborating on the Merkel cell carcinoma, my lab, isolating MAGE-A1 stuff that I haven't talked about today. A huge clinical team to carry out these trials, and Cassian Yi, who is now at MD Anderson, and my sources of funding. And with that, I'll take questions if there are any.